Good evening, everyone. Welcome to the ninth session of the JIPMER webinar series on target volume delineation. Today we are pleased to host a session on rectal carcinoma, MR anatomy and target volume delineation by Dr. Nidhi Gupta. Ma'am has done her MD and DNB in radiation oncology and has experience of residency in PGI Chandigarh, has been a senior consultant and headed the Department of Radiation Oncology in Grecian Super Speciality Hospitals in Mohali, and is presently assistant professor in radiation oncology in GMCH Chandigarh. Ma'am has extensive list of national and international publications, special interest in GI and breast, and has done major projects, single institute as well as multicentric. So, ma'am, if you are ready, we'll hand over to you for presenting your session.
Sure.
Thank you.
Is my screen visible?
Yes, ma'am, your screen is visible.
Okay. Good evening, everyone. First of all, I'd like to congratulate the organizing team at JIPMER for planning such a useful academic program, which is benefiting everybody. And I'm really thankful to the organizing team at JIPMER for giving me an opportunity to be a part of this wonderful academic program. Thank you, Dr. Chandramoulu, for such a wonderful introduction and kind words. Okay, has my slide moved?
Yes, ma'am, your slideshow is going.
Okay. So today I've been given the responsibility of discussing with everybody the MR anatomy of the rectal cancer and the target volume delineation. So the sequence in which we will be discussing this will be, first we'll discuss in detail the MR anatomy, what are the indications for radiotherapy, what are the various guidelines which are available for the target delineation, and then which is the most commonly followed consensus guidelines. We'll discuss them in detail, and then the most commonly followed radiation schedules, the short course RT and the long course chemo-RT. Okay, first of all, let us begin with the investigative workup. So as a minimum, you will require an endoscopy. This endoscopy is going to give you an extent of the growth, the nature of the growth, the dimensions of the growth. It is going to tell you the distance of the tumor from the anal verge, about the circumference involved by the growth, and most importantly, it is going to give you the biopsy which you require for the histopathological proof of malignancy. So other than that, we'll require a baseline serum CEA, hematology, and biochemistry. Now, MRI pelvis is considered to be the gold standard for the staging of the rectal cancer. And it will be not an overstatement if I say that it is regarded as a platinum standard. Okay, so very often it happens that when we see the rectal cancer patients, they already present to us with a CT abdomen and pelvis from outside. And then we are a little reluctant that whether we should again prescribe them MRI pelvis or not. So please let me assure you that what information we get on the MR pelvis, we are not going to get on the CT. So please don't feel guilty when you have to advise a MR pelvis to the patient of CA rectum who is already presenting to you with a CT scan of the pelvis. Okay. The endorectal ultrasound can never be a substitute for MR pelvis because the field of vision of the endorectal ultrasound is narrow. So it is not going to give you an idea about the circumferential resection margin, the mesorectal fascia, or the lymph nodes. So the endorectal ultrasound can be considered if the MR is not available, or there are certain contraindications for MR. For example, the pacemaker, the patient has a pacemaker in situ. So for those conditions, you can take an endorectal ultrasound, but otherwise MR pelvis is the standard and there is no substitute to it. As a part of the systemic workup, you'll need a CT abdomen and chest. PET scan is not required for the primary staging of the rectal cancer. However, there are sometimes situations in which the CT scan is equivocal and you need to pull out the systemic meds, which is going to take your management. So in those cases, it is reasonable if you go for a PET scan, but not for the primary rectal cancer staging. Okay, now as important it is to get a MR pelvis for the patient, equally important is that we should get this MR done with a proper protocol. So the equipment should be minimal a 1.5 Tesla. If it is a 3 Tesla equipment, even more better. And what we require is simple T-weight images in the sagittal, coronal, and axial sections. We do not require contrast. We do not require the T1 weight images. We do not require the functional images. Okay, so what is important for us? A good equipment with T2 weight images in all the 3 sections, sagittal, coronal, and axial, and the slice thickness should not be more than 3 mm. Spasmolytic agents can be used because they help to reduce the peristalsis. IV contrast is not required, but sometimes what happens is that the radiologist insists for the IV contrast if he's suspecting some mucinous kind of tumor. So in those cases, what you can do is that you can acquire your non-contrast images first, and then that can be followed by the IV contrast. Because the non-contrast T-weight images are a must. T1 images with or without contrast are not required. Diffusion weight images are not required. However, if we are doing the MR for a rectal cancer to assess the response to neoadjuvant radiation, in those cases, we require a functional imaging, the diffusion weight images. But for the primary rectal cancer staging in a treatment-naive patient, this is not required. It is useful to assess the response after neoadjuvant treatment. Endorectal coil is not required and rectal distension with gel is not required. Okay, now we'll begin with the MR anatomy. First of all, the extent of the rectum. We all know that it extends from the anorectal junction to the rectosigmoid junction. Okay, now the anal canal is approximately taken as 3 centimeters from the anal verge, and the rectosigmoid is roughly taken as 15 centimeters from the anal verge. Now the anorectal junction is marked by, there is a sudden increase in the thickness of the muscle layer, which is due to the presence of the internal anal sphincter. And you can also feel the superior border of the puborectalis. So this is going to be your anorectal junction where you'll suddenly feel an increase in the thickness of the muscular layer. And the rectosigmoid junction is marked by the place where the vertical rectum becomes the horizontal sigmoid. So this is also called as the sigmoid takeoff. So between this anorectal junction and the rectosigmoid, we'll have the 3 parts of the rectum, the upper, middle, and the lower. Now, if you look at the MR, the lower rectum is taken as 6 centimeters from the anal verge up till the anorectal junction. Okay, so this yellow line. So 6 centimeters from the anal verge up till the anorectal junction is your lower rectum. Now, this is a very important landmark for the rectal cancer, and this is called as the anterior peritoneal reflection. This is the point where the peritoneum attaches itself on the anterior wall of the rectum. We're going to discuss this in detail. So the part of the rectum which is above the anterior peritoneal reflection is considered to be the upper rectum. So the part between the rectosigmoid junction marked by this red arrow to the attachment of the anterior peritoneum, this pink part is considered as the upper rectum. And the part between the two of them is going to be your middle rectum. Now coming to the blood supply of the rectum, we have the superior rectal artery, the middle rectal artery, and the inferior rectal artery. The inferior rectal artery and the middle rectal artery are branches of the internal iliac arteries. But what is most important for us is the superior rectal artery. Why this is important is because this serves as a landmark for the target delineation. When we are going to study the guidelines for target delineation, the cranial border of the mesorectum, it is taken at the bifurcation of the inferior mesenteric artery into the superior rectal artery and the sigmoid artery. So look carefully. This is the aorta. From the aorta, we are going to get an inferior mesenteric artery roughly at the level of L3. And this inferior mesenteric artery initially gives a left colic branch, and subsequently it bifurcates into the superior rectal artery and the sigmoid artery. So this point of bifurcation, it roughly occurs at the level of the sacral promontory, and this is the part where we take the cranial border of the mesorectum. Now, if you look at the MR image, then these superior rectal vessels will be occurring at the level of the sacral promontory. Now coming to the peritoneal attachments of the rectum. Now in the upper part, the peritoneum attaches to the rectum both anteriorly and laterally. As we go a little down, the peritoneal attachment is only on the anterior part of the rectum, and the lateral part of the rectum is devoid of this peritoneal attachment. Then after a little, attaching itself on the anterior wall, it reflects back. So the lower rectum is going to be devoid of any kind of peritoneal covering. Now, if you look on the MR, so on the MR, this is the point which corresponds to the anterior peritoneal reflection. And this is best appreciated if there is some small fluid in the peritoneal cavity, because this is a dependent portion. So it is going to accumulate here. So this anterior peritoneal reflection is again a very important landmark, because one, the part above this anterior peritoneal reflection is considered to be the upper rectum, which has a good prognosis and better outcomes. Second is that involvement of this anterior peritoneal reflection makes it a T4 disease. Okay, so if this is involved, it becomes a T4 disease. Now, when you look on the axial section, this attachment of the peritoneum on the anterior wall of the rectum is seen as a V-shaped T2 hypointense line, and this is called as the Siegel sign. So here, where the peritoneum is attaching on the anterior wall of the rectum, it will be visible on the axial MR image as this typical V-shaped Siegel sign, and this involvement will be a T4 disease. Okay, now we come to the fascias of the rectum. Now, the rectum is enclosed, or you can say cushioned, by a layer of adipose tissue. And this adipose tissue is called as the mesorectum. This mesorectum, it encloses the lymphatics, the blood vessels, and the nerves. Now, this mesorectum is bounded by the mesorectal fascia. And this mesorectal fascia is actually the visceral fascia of the rectum. So if you look in this image, this is going to be your rectum. This white area is going to be your mesorectum. And this blue line is the mesorectal fascia, which is actually the visceral fascia of the rectum. And outside this visceral fascia, we'll be having a parietal fascia. And this parietal fascia will have a different name depending upon its location. So here, when it is gold standard, okay. One of the major reasons is that the MR can very reliably, to the tune of 95%, it can predict the T state of the tumor. So we look here into the MR image. This dark color T2 hypointense line, this is the mucosa. This is usually very difficult to visualize on the MR. And when the tumor is involving the mucosa, it is called as carcinoma in situ. Okay. Now, this area marked by the blue arrow is the submucosa. Now, when the tumor extends into the submucosa, it becomes a T1 tumor. So here you can see that if it is partially involving the submucosa, it will be T1 submucosa half. And if it is involving the full thickness of the submucosa, it will be submucosa 3. That is, the full thickness is involved. These are the, the substages which are taken on the MR staging. If you look at the clinical staging, it is a post-op staging, the TNM staging. It is a post-op histopathological staging. So it will not give you these substages. These substages are applicable only to the MR. So we are currently discussing the MR staging of the rectal cancer, the T stage. So when the tumor has involved the submucosa marked by this blue line, so we are dealing with the T1 tumor. Now the subsequent of this is the muscularis layer. Okay, so this green arrow is the inner circular layer, and this purple arrow is marking towards the outer longitudinal layer. And these two layers are separated by thin film of adipose tissue. So here you go see if the tumor is only involving the inner circular layer, it is labeled as T2 early. And if it is extending to involve the outer longitudinal layer as well, it becomes T2 advanced. Next is when the tumor goes beyond the muscularis. Okay, so I've seen that many a times when we are staging the rectal cancer tumor in the clinics, there is a lot of confusion because T2 is also invasion into the muscularis and T3 is also invasion beyond the muscularis. So I've often seen that the residents get confused with the post-op report. So just get it clear that if your tumor is involving the muscular layer, circular or longitudinal, it is T2. And if it is going beyond the muscularis into the mesorectum, it becomes T3. So when it goes beyond the longitudinal muscular layer into the mesorectum, it is T3. Now this T3 has been substaged on the MR into A, B, C, and D. The T3A tumor is when the tumor extends into the mesorectum only up till 1 mm. And T3B is when it is going to extend into the mesorectum up till 5 mm. T3C is when it is going to go up till say 15 mm, and T3D is when it is going to go beyond 15 mm. Okay, so this is the substages of the T3. Now this is very important because once a tumor is T3, that is, it has gone into the mesorectum, it becomes an indication for neoadjuvant treatment. And there is some discrepancy. If you look at the NCCN guidelines, the NCCN guidelines will say that all T3 patients should be treated with neoadjuvant treatment. Whereas the European guidelines will say that T3A can be taken up directly for surgery, whereas T3 beyond, that is when it is more than 1 mm in the mesorectum, they should be taken up for neoadjuvant treatment. So one should understand these substages of the T3. And then we have the T4 stage. In the T4 stage, if it is involving this V-shaped anterior peritoneal reflection, the Siegel sign, it becomes T4A. And if it is involving the anterior pelvic organs, the uterus or the prostate, then it becomes T4B. Now, apart from the T stage, the reason why the MR is considered to be the gold standard for rectal cancer staging is its ability to predict the circumferential resection margin, the CRM. Okay. Now, what is this CRM? Traditionally, we always follow the proximal and the distal margins. But in rectum, we have just discussed that the plane of surgery is located outside this mesorectal fascia. So this black dotted line, okay, this is representing the plane of rectal surgery. Now, this plane of surgery is called as the circumferential resection margin. Why? Because it is involving the circumference of the rectum. So you see CRM. So it corresponds to the circumference of the rectum. So it is called as the circumferential resection margin. Now, this is labeled as the distance between the lateral most extent of the tumor and the plane of resection. That means the primary tumor, or if you have a tumor deposit, or you have a lymph node. So whatever is the most lateral towards the mesorectal fascia, the distance from this lateral most tumor extent to the plane of resection is going to be your circumferential resection margin. Now, there's great significance attached to the circumferential resection margin, because if you are having a positive circumferential resection margin post-operatively, this is a post-operative entity. Okay, so post-operatively, you'll get to see in your specimen that whether the CRM is positive or negative. So if you have a positive CRM, then the local control rates drastically drop from, say, a local recurrence of 7%, it will increase to 20% local recurrence. And similarly, your overall survival will decrease from 62% to nearly 40% if you have a positive CRM. So positive CRM is one of the worst adverse prognostic factors. And there is a landmark Mercury trial, which has, confirmed the accuracy of this MR in predicting the CRM very reliably. Now, how do we predict the CRM on the MR? Now, we have studied the T3 stages, A, B, C, and D. So the MR is going to look into the extent of this tumor into the mesorectum, and what is the distance of this tumor or the tumor deposit or the lymph node, and look at its distance with respect to this mesorectal fascia. Okay, now this mesorectal fascia, you can see it is a T2 hypointense dark colored line, which is not in continuity. It is usually a broken line. So you have to extrapolate it at places. And sometimes, like here, you will see multiple layers of these lines. This is because, we've just seen that the mesorectal fascia is juxtaposed with the presacral fascia. So when you see the multiple lines, you have to consider the innermost line, because the innermost is going to be your mesorectal fascia and the outer one is going to be your parietal fascia. So the MR is going to look at the distance of the lateral extent of the tumor from the mesorectal fascia, and based on that, it is going to predict your CRM. So if the distance of the lateral extent of the tumor is less than 1 mm from the mesorectal fascia, it is going to predict that you are going to have a positive CRM. If the distance is 1 to 2 mm, then it predicts that you have a threatened CRM. And if it is more than 2 mm, then it is going to say that you have a free CRM. So like we have a weather forecast. So similarly, the MR is going to forecast for you that what is the likely post-op circumferential resection margin. So based upon this, you have to plan your surgery. So if you have a positive or a threatened CRM, you cannot just operate this patient upfront. You have to take this patient for neoadjuvant treatment. So these are the examples. You can see this is a T3B tumor. So T3B tumor was when your tumor is going up till 5 mm into the mesorectum. So here you'll have a clear CRM. And then this is a T3D tumor where you are going to have more than 15 mm extension into the mesorectum. And you can see that this is involving the mesorectal fascia. This is a positive CRM. So this MR is going to forecast a positive CRM for this patient. So this patient should not be operated and should be taken for neoadjuvant treatment. So you can understand that you cannot get all this information on the CT. So please get a MR for the patient of rectal cancer whenever you have a patient with already existing CT also. Now we come to the lymph nodes. The most commonly involved lymph nodes in the rectum are the mesorectal lymph nodes. Okay, and other than that, we will have the iliac group of lymph nodes. So this is the internal iliac lymph node. And because, the mesorectal lymph nodes are located close to the rectum, these can be labeled as the central group of lymph nodes. So these become the lateral group of lymph nodes. This nomenclature has been used in the guidelines. So normally we do not use the terminology lateral lymph nodes for the pelvic lymph nodes. So here they refer to the internal iliac group of lymph nodes as the lateral lymph nodes. They're also called as the extra mesorectal lymph nodes. Other than that, we have external iliac lymph nodes, the common iliac lymph nodes, and the inguinal lymph nodes, which are less commonly involved than these. Another characteristic finding of the rectal cancer patients is that here you will see that nearly 48% of the lymph nodes are less than 5 mm. So that means that the traditional size criteria, which we used for labeling a positive lymph node, is not applicable here. So therefore, apart from the size, we also have to look into other characters of the lymph node. So one is we look at the margins. If these margins are indistinct, then we look at the nature of the lymph node. If it is a heterogeneous lymph node, and then we also look at the shape. If the regular oval shape has been lost and it has become round in shape. So if a lymph node is more than 9 mm, it is always considered to be suspicious. But if you have a lymph node which is 5 to 9 mm, then you look for other characters. And if any of these two characters are positive, you'll again label this as a suspicious lymph node. And if the lymph node is less than 5 mm, then all the three characters need to be positive to label it as a suspicious lymph node. And if we look at the end staging, N1 refers to up till 3 suspicious lymph nodes, and N2 refers to more than 4 lymph nodes. And the TNM is also a similar stage for N1 and N2. Another thing is that if you have a node negative disease, okay, then T1 and T2 are labeled as stage 1, T3 and T4 become stage 2. But the moment you have a positive lymph node, then irrespective of the T, it becomes a stage 3 tumor. Another important characteristic associated with the rectal cancers is the extramural venous invasion. Okay, now what is this? So sometimes you have vessels which are very close to the tumor. So what happens is that the tumor directly gets deposited in the vessel. So this is again a very bad prognostic factor, adverse prognostic factor associated with poor outcomes. And it is also a predictor for systemic mets. So here you can see we have this tumor which is in proximity with the vessel. So it gets deposited in the vessel, and this is called as the extramural vessel invasion. So commonly it occurs adjacent to the primary tumor only, where the vessels are close to the tumor. Now looking at the sphincter complex. So here look at this. We have the circular layer, inner circular layer. As this inner circular layer of the muscle comes down, it changes into the internal sphincter. Then we have the outer longitudinal layer. We have the external anal sphincter, and then we have the levator ani. Now this levator ani comes and joins with the external anal sphincter, and this forms the sphincter complex. It is difficult to demarcate on the MR, but you can always appreciate this levator ani muscle. because this looks different. So this is your levator ani muscle, and then you will have the external sphincter, you will have the longitudinal muscle, and then you will also have the internal sphincter. Now, the lower rectal tumors have a very bad prognosis as compared to the upper and the middle rectal tumors. Now, this happens, one, because the pelvis is very narrow in the lower rectal region. So it becomes very difficult to get a R0 resection. Other than that, in the lower rectum, the lymphatic drainage is, more so laterally. So it tends to involve the ileal group of lymph nodes also. And other than that, the lower rectum, it goes into the systemic circulation. So there are more chances of systemic mets also. So on the MR, they have given a separate staging for the lower rectal tumors. Now let us look at this. If the rectal tumor is just confined to the bowel ball and it is not involving the muscle cord, it is called as stage 1. So this patient can be taken for low anterior resection. The sphincters can be spared, if the margin can be achieved. Stage 2 will be when the tumor involves the internal sphincter, but it has not reached into the intersphincteric space. So therefore, this patient can be taken for an intersphincteric dissection, which is less morbid. But if the tumor extends into the intersphincteric place, it becomes a stage 3 tumor, or if it is involving the external anal sphincter, or if it is involving the levator ani muscle. So then you have to do an extra levator APR, and that becomes a morbid surgery. Now looking at the ischiorectal fossa. Now the pelvic diaphragm is the place where the levator ani comes and joins the external anal sphincter. So when the levator ani joins the external anal sphincter, we call this the pelvic diaphragm. And the part above this is going to be the rectum, and the part below is going to be the anal canal. So roughly at the level of the pelvic diaphragm, you will see the ischiorectal fossa. This ischiorectal fossa superiorly, it will be, having the levator ani muscle. Here we'll have the external anal sphincter, and here the obturator internus and the bony pelvic wall. Posteriorly, it will be limited by the gluteus muscles. So here you can see the mesorectal fat has gone. It is almost parallel to the anal canal. So it is also called as the ischioanal fossa. Okay. So now we come to the stage-wise management of the rectal cancer. The rectal cancer is, I think, one of the best examples of a multidisciplinary approach. You cannot do away with a radiologist, a radiation oncologist, a medical oncologist, and the surgeon. So you need everybody to be together to give the best outcomes. So when we look into the stage-wise management, the T1 and T2 tumors, which are early stage tumors, nodes are negative, they are not going beyond the muscularis layer, they can be taken for upfront surgery. A good TME, is going to be sufficient. However, if you have a T1, T2 tumor, even in the lower rectum, then it might be encroaching the sphincters. And in order to increase the possibility of sphincter preservation, even in these early tumors, which are located in the lower rectum, you can give neoadjuvant treatment. Now, regarding the T3N0, there is little controversy. As I told you, the European guidelines say that T3-1 can be taken up for upfront surgery, whereas beyond that, you have to go for neoadjuvant treatment. So there is this one limited subgroup of T3N0 where you can consider upfront surgery. One is that it should not go beyond 2 mm into the mesorectum. It should have a good histology. It should not be a poorly differentiated tumor. There should be no LVI, no extramural venous invasion, and it should not be located in the lower rectum. So this is one subgroup of T3 tumors where you may consider upfront surgery. Other than that, all T3 tumors have to be taken up for neoadjuvant treatment. All T4 tumors, which involve the anterior pelvic organs, you have to take them for neoadjuvant treatment. All node positive patients, you have to take up for neoadjuvant treatment. Then other than that, if you have a positive or a threatened CRM, again, it becomes a definite indication for neoadjuvant treatment. And tumors of the lower rectal cancer, irrespective of the, the T stage, if you want to preserve the sphincter, you want a downstaging for the tumor, you want to improve your local control rates, so you can always take them for neoadjuvant treatment. Now, when we discuss about the neoadjuvant treatment, so whenever we talk about rectal cancer and radiation, please remember the radiation is always preoperative. So whenever you have to add radiation for rectal cancer, it has to be preoperative as compared to postoperative. the landmark German trial. It showed that, you know, the local recurrence rate are, when you compare pre-op versus post-op, for the pre-op radiation, the local recurrence is as low as 6%, and it doubles when you give post-operative radiation. Similarly, the sphincter preservation rates for pre-operative radiation will almost, you know, sphincter preservation will double up when you give pre-op radiation as compared to post-op radiation. So therefore, remember this, that whenever you discuss in your, you know, MDTs, the radiation for rectal cancer should always be neoadjuvant. Whenever you think the patient will need radiation, it has to be neoadjuvant. Then further, we see that addition of chemotherapy has been shown by various trials, the landmark trial being the French trial. It has shown that when you add chemotherapy to this radiation, your local control also improves and your pathological complete response improves significantly. Traditionally, they've been using 5-FU-based chemotherapy in infusion, but now over the years, capecitabine, oral capecitabine has been shown to have, you know, non-inferior results as compared to 5-FU infusion. So currently, the standard of care is neoadjuvant radiation along with concurrent capecitabine. And then we have the standard TME, which is required, a good TME. And this, depending upon the adverse prognostic factors, will be followed by adjuvant chemotherapy. Now, the various trials have failed to show any advantage in DFS or OS with the addition of adjuvant chemotherapy for rectal cancer tumors. So, however, based on the extrapolation of the results of the colon cancer, adjuvant chemotherapy continues to be prescribed to the rectal cancer patients. Recently, there are some meta-analysis which show some advantage, but more or less the majority favor that there is no DFS or OS advantage with the addition of adjuvant chemotherapy to rectal cancer. Now we'll start with the target delineation. First of all, you need to understand the subsites. Now, mesorectum we have discussed in detail. It is the most important subsite for the rectal cancer target delineation. This is followed by presacral space, and then we have the lateral lymph nodes. So again, I'll remind you, the mesorectal lymph nodes around the rectum will be called the central lymph nodes. So the lymph nodes which are located here, they'll be called the lateral lymph nodes. Now within this lateral lymph nodes, if you look, the internal iliac is located posteriorly and the obturator is located anteriorly. So what they label is that they label the lateral group of lymph nodes into a posterior group and an interior group. So it is just a nomenclature. So they're just referring to the internal iliac as the posterior group of lymph node and the obturator as the anterior group of lymph nodes. So when you read your guidelines, they talk in these terms. So it is important to understand, and simply because the internal iliac is posterior to the obturator, it is called as the posterior group and this is called as the anterior group. Okay, then we have the external iliac lymph nodes, the inguinal lymph nodes, ischiorectal fossa and the sphincter complex. Now, when we come to the guidelines, there are a lot of guidelines which are available and they have evolved over a period of time. The initial one of these was the one given by Rawls et al. In 2006. These people, they analyzed the failure rates of all the available literature at the local site as well as at the lymph node site. And then based upon these failure rates, they gave the recommendations for the target delineation. These were followed by the RTOG guidelines, which gave their volumes in terms of CTV A, B, and C, where CTV A was the essential target to be included in all patients, and CTV B and C refer to, you know, certain specific subgroups of the patients which would require those volumes. And then we had the Australasian guidelines in 2011, which mainly focused on the anal cancer, but they were very much applicable to the rectal cancer as well. The recent most and the most commonly used are the Valentini guidelines. So this is an international consensus, international recommendations, and these are the ones which we are going to discuss in details, and these are the ones which are used universally. Now, if you look at the various guidelines, you will see that, you know, the recommendations for all these guidelines are almost similar. They almost give similar recommendations and they talk about similar subsites. The only difference is the nomenclature is different. Every guideline is using their own nomenclature, so it becomes a little confusing. Otherwise, the message, the recommendations for the target delineation are almost similar with all the guidelines. So you look at this. This is the mesorectum. The mesorectum, as per all the guidelines, should be included in all patients, irrespective of the stage, irrespective of the location of the tumor. The presacral space, again, this should be included in all patients. The internal ileal group of lymph nodes, these should be included in all patients. So there is a consensus that these three subsites should be included in all patients as per all the guidelines. Now, if we come to the obturator group of lymph nodes, remember that whenever we have the tumor infiltrating into the anterior pelvic organs like the uterus or vagina or the prostate or the seminal vesicles, then there is a tendency to go, the lymphatic drainage goes laterally towards the external ileal group of lymph nodes. So whenever we have a T4 tumor, please remember that we have to include the obturator group of lymph nodes and we have to include the external ileal group of lymph nodes. There is some discrepancy or differences between the various guidelines in terms of the obturator lymph nodes, and we are going to follow the Valentini guidelines, which says that you should include the obturator lymph nodes if you are dealing with a T4 tumor or if you have positive internal iliac lymph nodes. So you're going to treat the next station. Internal iliac is positive, so you are also including the next station. And other than that, if you have N2 disease, that means more than 4 lymph nodes are positive. So that means you are dealing with a heavy nodal burden. So in that case, also include the obturator lymph nodes. For the external iliac, again, there is a consensus in all the guidelines that if you're dealing with a T4 tumor, which is involving your anterior pelvic organs, you must include the external iliac group of lymph nodes. Other than that, if your obturator lymph nodes are positive, so you go to the next station, you include the external ileal group of lymph nodes. Now coming to the ischiorectal fossa. See, the levator ani muscle constitutes a significant barrier to the spread of tumor from the anal canal into the ischiorectal fossa. So if you have a tumor which is simply located in the anal canal, that does not become an indication to treat the ischiorectal fossa. So only if the tumor is infiltrating and reaching up to the external anal sphincter, or it is invading into the ischiorectal fossa, only then it becomes an indication to include the ischiorectal fossa. Similarly, for the inguinal lymph nodes, if you have a tumor which is predominantly rectal and then it is extending into the anal canal, it does not become an indication to include the inguinal lymph node until and unless the bulk of the tumor is in the anal canal and the muscle is involved, the internal anal sphincter is involved, the external anal sphincter is involved. So for superficial involvement of the anal wall, you don't need to include the inguinal lymph nodes. Only if it is involving the sphincters, you need to include the inguinal lymph nodes. If the inguinal lymph nodes are positive, and more importantly, if the lower third of the vagina is involved, then definitely you have to include the inguinal lymph nodes. Now coming to the patient positioning. Traditionally, there has been, a prone position recommendation because, to visualize the lower end of the anal canal, and also because, it gives us the bowel is displaced more from the field of radiation. But now when we are doing an image-based treatment, so the supine and prone, both positions are equally acceptable. What is important is that the position should be reproducible. The patient should be comfortable. So based upon that, you may take any position. The bladder protocol is important, in which you ask the patient, it is the one which is always followed in all the protocol, all the pelvic sites, that you ask the patient to void. Then you can ask the patient to take nearly 400 ml of fluid. And after around nearly 40 minutes, you can simulate your patient. Please do an examination before you simulate your patient. Sometimes, we have the MR films, we have the radiology, which is almost, 4 weeks, 6 weeks old. So please make it a point to do a digital examination before you simulate your patient. Marker at the anal verge. So if you feel that your volumes are limited to the pelvic diaphragm, I think you can do away with your marker at the anal verge. But if you expect that your volumes are going to go beyond the pelvic diaphragm, I think it is a good choice to take a marker at the anal verge. Now, these are the target delineation guidelines, the international consensus guidelines by Valentini et al. And their colleagues, which have been given, and this we are going to discuss in detail now. Now we'll start with the mesorectum, one because mesorectum is the most important, and second because traditionally in all other pelvic malignancies, we are not used to focusing on the mesorectum. So when we look at the mesorectum, the cranial border I already told you the cranial border is at the bifurcation of the inferior mesenteric into the superior rectal artery and the sigmoid artery. It's not, very easy because the vessel is not very thick, but it's not that difficult also. If you learn to trace the vessel cranially and caudally both, you scroll down, you'll be able to find the vessel. So look here at this vessel which has the maximum diameter. Okay, look at this vessel with the maximum diameter. As we go down, now this vessel is going to bifurcate. So this is the point, right? So here this vessel has bifurcated. So this was your inferior mesenteric. And as we go down here, the inferior mesenteric is bifurcating into the superior rectal and the sigmoid artery. And this is the level where you are going to take your cranial border of the mesorectum. So this image is from the guidelines. So you take a 7 mm margin around the vessels and you exclude the bowel, and this becomes your cranial border of the mesorectum. Now, if you trace these rectal vessels inferiorly, you go down more, they appear like this. So they appear like this. So these are the, the superior rectal vessels, which we also saw on the MR. So if you learn to scroll them down cranially and caudally, you'll be able to track out this, superior rectal here. This is the bifurcation of the inferior mesenteric. Here it is bifurcating. And as you go down, this becomes these elongated vessels. So this is the cranial border, and it roughly corresponds to the level of the sacral promontory. Now coming to the caudal border of the mesorectum, the caudal border is where your levator ani is going to come and insert into the external anal sphincter, and your mesorectal fat is going to disappear. So here you can see this is the mesorectal fat, and this is the levator ani, and this is the rectal wall. Now you trace it down, the levator ani is going to approach and merge with the rectal wall, and the mesorectal fat is going to disappear. So as we go down, you can see the levator ani is approaching the rectal wall. Here it is nearly merging with the rectal wall, and the mesorectal fat has also disappeared. So this is the section where you are going to mark your caudal extent of the mesorectum. So here you see, you cannot see the levator ani separately, and the mesorectal fat is also not visible. So this is going to be your caudal end of mesorectum. Anteriorly, in the upper pelvis where you have the vessels, you're going to take a 7 mm margin around the vessels and exclude out the bowel. And as you go down into the pelvis, you will have your anterior pelvic organs. So you remain behind these, that will form your anterior border of the mesorectum. And posteriorly, you have to be abutting the vertebra, the sacral vertebra. So you are just adjacent to the sacral vertebra, that is your posterior border. And laterally, you have to ideally, lateral border is along the mesorectal fascia. But the mesorectal fascia is very difficult to identify on the CT. So, at least you can bound your lateral boundary with mesorectum. In a good CT, I think mesorectum is easily visualized. So even if you cannot, make out the mesorectum, so you remain medial to the vessels. So here you'll have your vessels. So you remain medial to the vessels, and ideal will be that you cover your mesorectum. And as you go down, you have to remain inside the levator ani. Okay. And here I'm trying to show you that in the CT, you can make out the mesorectum, not the mesorectal fascia, but the mesorectum can be made out. Even as you go down, you can make out the mesorectum and you can make out the levator ani. Now then we come to the next subsite, that is the presacral space. Now in the Valentini guidelines, they have divided this presacral space into a pelvic presacral space and an abdominal presacral space. This pelvic presacral space has to be included for all patients. Okay, and the cranial limit of this pelvic presacral space, it corresponds to the mesorectum. So it begins at the mesorectum, where the inferior mesenteric is going to bifurcate into the superior rectal and the sigmoid artery, and caudally also it is parallel to the mesorectum, so it is going to go up till the pelvic calcium. Now the rest, here you mark it anteriorly, a 1 centimeter margin in front of your sacral vertebrae. So the posterior margin is going to be abutting the sacral vertebra, and the anteriorly you are going to have a 1 centimeter margin, and later it is going to go up till your sacroiliac joints. Okay. Now, practically speaking, you will not have to contour this pelvic presacral space. The reason being that when you contour your mesorectal subside and you contour your lymph node subside, then this presacral space automatically comes within these two subsides. So this practically becomes a virtual space which you don't have to contour, and it is automatically confined when you will finalize your volumes with the mesorectal volume and your the lymph node volume. Now coming to the abdominal presacral space, the abdominal presacral space is not to be included routinely. It is to be included only if you have a positive lymph node in the abdominal region. So here, cranially, it is going to start at the bifurcation of the aorta into the iliacs, and caudally, it is going to go up till your pelvic presacral space at the level of the sacral promontory. Anteriorly, the guidelines say that you have to take a 1 centimeter margin anterior to this lumbar vertebra. Okay, so surprising enough, they do not recommend a margin around the vessels. See, get it clear. The guidelines do not recommend a margin around the vessels. They recommend a 1 centimeter margin anterior to the lumbar vertebra. So that may or may not completely cover your vessels. Laterally, however, they say that you go to the extent to cover these vessels, but anteriorly, you just have to take a 1 centimeter margin. Now we come to the lateral group of lymph nodes. Now, please remember the nomenclature. The lateral group of lymph nodes, posterior group refers to the internal iliac group of lymph nodes. So now we are going to talk about the internal iliac group of lymph nodes. So these are the lymph nodes which we are very used to marking traditionally for all the pelvic malignancies, and more or less the the guidelines are almost similar. So they are going to begin where there is the bifurcation of the common iliacs into the external iliac and the internal iliac. So here we go down, and as we go down, you can clearly see that the bifurcation is occurring. And this section where you can see your internal iliac and you can see your external iliac, this forms the cranial border for the marking of the both internal iliac and the external iliac. So this is the cranial border where the common iliacs have split into the internal and external iliac. The caudal limit is taken up till the pelvic diaphragm, and where the point where you can see here the obturator vessel is leaving into the leaving the pelvis and entering into the obturator canal. So basically, remember that you have to go down up till the pelvic diaphragm. As long as there is a space between the obturator internus and the mesorectum, you can go ahead, contour your internal iliac group of lymph nodes. And here they are also including the obturator group of lymph nodes. We'll discuss them later. Now coming to the anterior border of the internal iliac group of lymph nodes. Now the guidelines say that the anterior border is taken in a virtual plane which is formed by the point of insertion of the ureters into the bladder. So the imaginary plane where the ureters are going to come and insert into the bladder, that is taken as the anterior limit of the internal iliac lymph node. Practically, more easy landmark will be to be at the anterior border of the obturator internus. Okay, so if you are at the anterior border of the obturator internus, your internal iliac lymph nodes will be covered. And if you look posteriorly it is going to recommend that you are going to be, just abutting your sacral vertebra. So along, just parallel to the mesorectum. So here you can appreciate that your presacral volume is automatically going to come into your mesorectal and your lymph node volume. So you don't have to struggle to contour the presacral volume. Okay. Now next we have is the, okay, in this section, I'm trying to show you that if you want, you can track the ureters. Now look at this point, okay? As I scroll down, you'll see the ureters entering into the bladder. Here. So can you see? There, the ureters are entering into the bladder. So it's not that difficult, but practically, even if you take at the anterior border of the obturator internus, it is okay. Now we come to the medial boundaries. So medial boundaries, you have to be outside the mesorectal volume. So you have to, be outside this. And if you look at the lateral boundary is going to be formed by your bones and your muscles. So here the pelvic side wall, and here you have the iliopsoas muscle. That is going to form your lateral boundary. Now coming to the obturator lymph nodes. Now, as I told you, traditionally what we do is we take the internal iliac lymph nodes, we take the external iliac lymph nodes, and then we fill the gap between them with a 15 mm brush, and we get the obturator lymph nodes. This is what we do traditionally. Now here what you do is, first of all, remember that obturator lymph nodes are not to be included in all the patients. So you have to include the obturator lymph nodes only for those patients where you will have a T4 tumor going into the anterior pelvic organs, where you are going to have, bulky nodal disease, more than 4 lymph nodes are positive, or when you already have internal iliac lymph nodes positive, so you want to treat the next patient. So here, the anterior border. So when you are treating only the internal iliac, you remain posterior to the anterior border of the obturator internus. And when you are going to treat the obturator lymph nodes, you go ahead and remain posterior to the external iliac. Okay, so these are the external iliac vessels. So you remain posterior to them. So you're including the obturator lymph nodes. If you remain at the level of this obturator internus anterior border, you're treating only the internal iliac lymph nodes. And inferiorly again, it is going to go up till the pelvic diaphragm. Here the obturator artery is leaving the obturator canal. Again, you are going anterior to the obturator internus muscle. So you're including the obturator lymph nodes also. Now next will come the external iliac lymph nodes. Again, important to know, external iliac lymph nodes are not to be contoured routinely for every patient. So when do you take them? When you are dealing with a T4 disease, or when the obturator lymph nodes are positive. So the cranial border we have already discussed. It is going to be at the bifurcation of the common iliacs into the external and the internal iliacs, and the caudal border. So the caudal border is going to be where the external iliac vessels, they form the femoral vessels. So at what point does it happen? So here you look, the point at where the bony pelvis appears. So you have the superior pubic ramus. So this section before the superior pubic ramus is going to be your external iliac lymph node, and the section after the superior pubic ramus is going to be your inguinal lymph node. So you start from the bifurcation of the common iliacs, and then you continue till the external iliac becomes the inguinal lymph nodes. Other than that, the lateral margins, we all know, you take a 7 mm margin around the external iliac vessels. However, the guidelines recommend that in the anterolateral direction, parallel to the iliopsoas, you take a 1.5 margin instead of your 7 mm. Okay, this is to treat the anterolateral group of lymph nodes. So other than that, you have the 7 mm margins. Posteriorly, you are going to be limited by your external iliac vessels and the margin of 7 mm. Now coming to the inguinal lymph nodes, again, I like to emphasize when you have to take your inguinal lymph nodes. Please remember, just a tumor extending into the anal canal does not become an indication for treating the inguinal lymph nodes. Okay, so if your tumor is, bulky, when it is in the anal canal, the bulk of the tumor is in the anal canal. It is not a superficial tumor. It is involving the internal anal sphincter. It is involving the external anal sphincter. It is going towards the muscle layer. Okay? Or it is involving the lower 1/3 of the vagina. And obviously, if you have a positive inguinal lymph node, then you have to treat these inguinal lymph nodes. Now coming to the borders, the cranial border we have already discussed. So when after the superior pubic ramus, this is going to become the inguinal lymph node. Regarding the caudal border, there is a lot of discrepancy. Some guidelines say that where the saphenous vein is going to come and join into the inguinal vessels, that section. Some say that you take a margin from the point where the saphenous vein is going to come and join into the inguinal vessels. And some say where your adductor longus is going to be crossed by the sartorius. So there are a lot of landmarks, but I think practically the most useful and one which is a compromise of all these different suggestions is that you take the inferior limit of the ischial tuberosity. So the inferior level of the ischial tuberosity marks your caudal border of the inguinal lymph node. Now, coming to the anterior and posterior extent, anteriorly you have to take a 2 centimeter margin around these vessels, and this is to include all the lymphoceles and all the lymph nodes which might be there along with the vessels. And posteriorly, we know it is going to be formed by the muscles, the borders adductor longus, the iliopsoas, and the sartorius. Now coming to the ischiorectal fossa. So the ischiorectal fossa is going to be below the pelvic diaphragm. So here you will have the levator ani muscle, which is going to come and join the external inner sphincter. So this is going to form the roof of the ischiorectal fossa. Here we'll have the obturator internus, the levator ani, which is coming and joining the external inner sphincter. This is the roof, and the floor is going to be formed almost by the anal verge. So you can see here, this is the anal verge. So this is going to form the floor. And if you look at the cross sections, so anteriorly, you'll have here the obturator internus and the bone, and here you'll have the levator ani, and posteriorly, they're going to be limited by the gluteus muscles. So you don't need to go posterior to this for the ischiorectal fossa, and most importantly, when to treat the ischiorectal fossa. So you have to treat the ischiorectal fossa only when this levator ani is involved. So external anal sphincter is involved, or the tumor is extending into the ischiorectal fossa. Simply the involvement, superficial involvement of the anal canal does not merit the treatment of the ischiorectal fossa. Now coming to the margins, in the mesorectal volume, which is located posterior to the bladder, you need to give an ITV. So only an anisotropic means that asymmetrical, only anteriorly. In the position where it is close to the bladder, you give a 1 centimeter anisotropic margin to account for the bladder and the uterus movement. And other than that, you give your PTV, which is going to be as per the institutional protocol. It can be 7 mm, 10 mm, or even 1.5 mm. Now coming to the dose schedules, the most commonly used dose schedules, we have 2 dose schedules. One is which uses 180 centigrade per fraction and goes up till a dose of 45 to 50.4 gray. It is called as the long course RT. It also gives concomitant capecitabine at 825 milligram per meter square. So it is called as the long course chemo RT. And other than that, we have a short course RT in which we give 5 fractions of 500 centigrade. And this is not given concomitant with chemotherapy. We'll discuss this in detail. Coming to the boost. So usually what we do is that we give the 45 gray volume to the entire volumes, and then the remaining boost up till 50.4 gray is given to the boost volume. So how do you plan this boost? So you look at the GTV, and from the GTV you take a cranial and a caudal margin of 2.5 to 3 centimeters, and then you extend this margin circumferentially to involve the mesorectum and to involve the presacral area. So this forms your boost volume. So you take a cranial caudal margin and then you involve the extend it to the mesorectum and the presacral area, and you get your boost volume. Okay, and then you can boost it up to 5.4 gray in 3 fractions. And then we also have, if you want to give a simultaneous integrated boost to the lateral pelvic lymph node. So if you have an internal iliac group of lymph node which is not going to be dissected and you want to boost that lymph node, you may just give a 1 centimeter margin around the lymph node, and then you can simultaneously boost it to 50 gray or 54 gray, as much as you want, keeping in mind those constraints for the organs at risk. Traditionally, the rectal cancer can be very well planned with a good conformal plan. You use 3 fields, 2 lateral and 1 posterior, and you get a very good coverage. And your bowel is also spared very nicely. However, there are certain indications for which you will definitely need IMRT, and these will include if you want to cover the external iliac lymph node, the inguinal lymph nodes, if your bowel constraints are not being met with the conformal radiation, if you're using very large portals, if you want to simultaneously boost your pelvic lymph node, or if you are re-irradiating a patient. Now, we'll discuss this in a little more detail, the short course RT and long course RT. So when to give a short course RT and long course RT? If you look at the various literature, there are no clear-cut demarcations that when you should use the short course RT or the long course RT. In fact, the recent literature, the POLISH trials, the TROG trial, they have shown that when you use short course RT or long course RT, there is no difference in the local control. There is no difference in the overall survival. There is no difference in the sphincter preservation, and there is no difference in the late toxicity. So, the recent literature is saying that the short course RT is equivalent to the long course chemo RT. Okay, but however, in spite of this, we see that the downstaging is better. It is more in the long course chemo RT protocol. So first of all, talking about the protocol, 180 centigrade you give, and you can go up till 45 to 50 gray. Here you give 500 centigrade in 5 fractions. You give concurrent chemotherapy. You do not add concurrent chemotherapy. This is usually followed by surgery within 1 week to 10 days. But now in the newer literature, we can also wait similar to the long course RT and then operate. And here we always wait for 6 to 8 weeks. Now, so when you need downstaging of your tumors, that is the time when you can opt for the long course chemo RT. That means if you have a threatened or a positive circumferential resection margin, you have a T4 tumor, your sphincter is very close to the plane of resection, lower rectal tumors, which you want to preserve the sphincter and get better local controls. You are aiming for organ preservation, and you have a good G6 patient who can tolerate this long course with chemotherapy. So here you can definitely opt for the long course chemo RT schedule. But if you have a T3 tumor, the circumferential resection margin is clear, and you just want to give RT because you want to decrease the local recurrence rate, and your tumor is located in the upper or the middle rectum, and you have elderly patients. So here you can prefer the short course RT. Now, just briefly, I'm going to talk about a couple of promising approaches. One is the total neoadjuvant treatment. So first of all, what do you understand by total neoadjuvant treatment? So traditionally, we are going to give a long course RT. We're going to give a gap of say 6 to 8 weeks, and then we are going to operate. So now what happens in the total neoadjuvant treatment is that in that gap after neoadjuvant chemo RT, when we are going to wait before surgery, they add the chemotherapy, the systemic chemotherapy. And what is the logic behind doing this? Traditionally, it is seen that we have brought down the local recurrence rate first with TME from 30% to 10%, and then with a neoadjuvant radiation, the local recurrences have further dropped down to almost less than 5%. But the systemic failures have remained constant over all these years. The reason being, one is because of the poor compliance to systemic adjuvant chemotherapy after radiation and surgery, and other because it is more, a disease which is having a systemic spread as well. So here, to increase the compliance to chemotherapy, they took this logic that we should add chemotherapy pre-operatively. Okay, we add the systemic chemotherapy pre-operatively in the time interval when we are waiting for the surgery. So what happens is that you get an increased compliance to chemotherapy, you decrease your systemic failures, and more importantly, you get a better pathological complete response. So you are definitely adding chemotherapy to radiation, systemic consolidation chemotherapy. So you are adding two modalities before surgery. So your PCR goes up, and most importantly, you are decreasing your overall treatment time. So the overall treatment time significantly comes down when during the waiting period, you are giving the consolidation chemotherapy. So it definitely looks a very promising approach, and it may become the standard of care in the near future. However, currently, there is no consensus on whether, we should give radiation first, we should give consolidation chemotherapy later, or we should give chemotherapy first and radiation later, or, we should use a long course RT or we should use a short course RT. So these all are still under review, but definitely this appears a promising approach. Other than that, we also have organ preservation. So what do you understand by organ preservation is that we do not operate upon the rectum. Okay, so the rectum is intact. Rectum has not been operated. So this is the organ preservation approach. However, this involves that you give a neoadjuvant treatment, then you assess the clinical response of the patient. If you have a complete clinical response, then you keep this patient on a close follow-up, and subsequently, you have to be very diligent in the follow-up so as to pick up any tumor regrowth which may occur, so that once you have a tumor regrowth, you can immediately take up this patient for salvage surgery, and thus your overall survivals are not compromised. So this is the logic. Okay, but it is not very simple. Reason, you have to take a selected group who can be approached for this organ preservation. Not all patients can be approached. T1 tumors, T2 tumors, T3 early tumors, A and B, then N0 tumors preferably, or N1 tumors which do not involve the entire circumference of the rectum, and the size is less than 5 centimeters. After that, the next challenge remains to diagnose a complete clinical response. Okay, so in a post-RT patient, using a MR, using an endoscopy, and using a digital rectal examination, it is not easy to diagnose a complete clinical response. Subsequently, you have to keep the patient on a very stringent follow-up, which will again involve MR, endoscopy, and digital rectal examination. And the patient has to be very compliant because, if you fail to detect the regrowth at the correct time, so you will make the patient unresectable. You will compromise on the overall survival. So the regrowth has to be detected at the right time to be able to salvage it with surgery. So this looks a very attractive approach, and you can further increase your pathological complete responses, or you can increase your response rate from the conventional 20 to 30% if you decide to add consolidative chemotherapy also along with the neoadjuvant. So if you do a TNT approach, your organ preservation rates are going to further increase. And you also have an option that you can increase the radiation dose if you're planning for rectal preservation. So in that case, instead of stopping at 50 gray, you can boost these patients with either your IMRT, or you can boost them with brachytherapy, or you can boost them with contact X-rays, so that you can give a higher dose, maybe up till 60 gray, keeping in view the bowel constraints, and then you increase the chances of a complete clinical response in these patients. And this is traditionally, it had been initiated by Madam Haber-Gamma, and it is also called as the Haber-Gamma approach. And she herself is a surgeon, and she has opted for this non-surgical approach. So now I'll summarize. First of all, it is that, rectal cancer is the best example of a multidisciplinary approach. You need a radiologist, you need a surgeon, you need a radiation oncologist, and you need a medical oncologist. So until and unless all of them work together, you cannot get the best outcomes. And the aim is to give the best local control, best survival with sphincter preservation, and a good quality of life for the patient. For the target delineation, remember the mesorectum, the presacral area, and the internal iliac lymph nodes have to be delineated for all patients, irrespective of the stage, irrespective of the site. For other subsites, you need to look into that which stage or the site recommends the particular subsite to be delineated. And regarding the short course RT and long course RT, there are no definite indications. But if you're looking for a tumor downstaging, go for long course chemo RT. Total neoadjuvant therapy and organ preservation, they are very promising, and they have great potential, and they are likely to become the standard of care in the near future. I'd like to acknowledge these websites from where I picked up the CT images and the MR images. And I'd like to thank you for your patient listening, and I'll be happy to answer any questions if you have.
Thank you very much, ma'am, for the very crystal clear presentation and clarification of the doubtful areas, and for your elaborate presentation, ma'am. Ma'am, some doubts are there.
Sure. Please, let me know.
Ma'am, regarding inguinal nodes, actually prophylactic versus therapeutic. If there are no inguinal nodes, and suppose there is an indication for prophylactic nodal irradiation, how much dose to be delivered, ma'am? The usual dose or 45?
See, if by prophylactic you mean that, I told you that prophylactic is not given. It is given only if you have definite indications. If your inguinal lymph nodes are involved, if your external anal sphincter is involved. Okay. So if you have this kind of a disease, which merits the inguinal node radiation, then it is not a prophylactic radiation. You have to go to a definitive dose. So then again, it depends that is your, if you, I mean, the lymph nodes are not palpable, then in that case, you can stop at 50 or 54 gray. But if your lymph nodes are palpable, you can even consider for lymph node dissection after your radiation.
Yes, ma'am. Regarding margins, when we are giving, whether to incorporate ITV in the case, especially for rectosigmoid malignancies, ma'am.
See, if your target delineation sections are running parallel to, say, the bladder or the uterus, then you expect there being a mobility and a variation. So in those cases, definitely a ITV should be included anteriorly of 1 centimeter. For the rectosigmoid, see, if you are dealing with a T1, T2 tumor of the rectosigmoid, then these cases should be taken for upfront surgery. Okay. And if you are dealing with a T3 or a T4 tumor, which is unresectable, and you are looking at downstaging of the tumor, then your volumes have to include the entire mesorectum. And when you include the entire mesorectum, you have to take the ITV.
Yes, ma'am. Thank you, ma'am. While giving this ITV margin, is an anisotropic margin recommended, ma'am, or
Yes.
yes, ma'am.
Yes, anisotropic margin to be given only anteriorly. You don't give it along the entire circumference of your volume. You just give it anteriorly, anisotropically 1 centimeter.
Okay. Regarding other doubts, actually, they've asked, can we give chemo first and then radiation in total neoadjuvant chemotherapy, total neoadjuvant therapy in rectal
Okay.
cancer?
Okay, so you see, there has been this opera trial. In this opera trial, they've taken both these arms. They have taken in one arm, they have given chemotherapy first, followed by radiation. And in the second arm, they have given radiotherapy first, followed by consolidation chemotherapy. So when you give chemo first, it is called as neoadjuvant chemo. When you give chemo after RT, it is called as consolidative RT. So overall, they do not show any significant differences, but your sphincter preservation or your downstaging of the tumor is going to be better if you are giving radiation first. Because when you give radiation first, you are going to give them a gap of 4 to 6 weeks till the time you're going to 6 to 8 weeks till you're going to complete your chemotherapy. So during this gap, we are going to expect that the radiation response is going to improve. There is going to be a more significant downstaging. So personally, I feel that if you have to give TNT, it should always begin with radiation first, and it should be followed by consolidative chemotherapy so that radiation gets that extra time for the tumor to downstage and for the response to occur.
Thank you, ma'am. And regarding the lower extent of delineating the inguinal nodes, some doubts were there, ma'am. Yes, ma'am. They were asking about the exact place where we have to stop the inferior border of inguinal lymph nodes during contouring.
Okay, so there have been, guidelines. There are one recommendation which say that you mark them till the point the saphenous vein comes and joins into the femoral vein. There is another guideline which says that you take a 2 centimeter margin beyond this point, where the saphenous vein is going to come and join into the femoral vein. You go distally 2 centimeter beyond that. And then there is again a recommendation which says that the point where the sartorius is going to cross the adductor longus, you take that. So between all these three, an ideal compromise is that you can go up till the lower border of the ischial tuberosities. They are easy to visualize also, and they seem like a compromise between all these three recommendations.
Yes, ma'am. Ischial tuberosity would be easy for us. And regarding, is there any difference in target volume between short course and long course chemotherapy, ma'am?
No. Guidelines do not recommend any difference.
Yes. And regarding adjuvant RT, some doubts are there regarding the indications of adjuvant RT and the target volume to be delineated for adjuvant RT.
Okay, see, if you are working in a proper MDT, so ideally your patient should not come to you for adjuvant RT. Okay, because you should be able to know on a good MR that you are dealing with a T1, T2 tumor, or you are dealing with a T3, T4 tumor, and your CRM and your lymph nodes. So ideally, at the baseline, you should be able to delineate that your case is a case for neoadjuvant RT or not. Still, however, if a T1, T2 tumor was operated and subsequently this case comes out to be T3 or T4, or there is a lymph node involvement, very high chances that the MR is not showing any significant lymph node, but on the post-op specimen you have a positive lymph node, or you have extramural venous invasion, or you have LVI, or so all these become indications for post-op RT. So you operated them thinking that it is a T1, T2 tumor, N0 tumor, CRM is clear, but post-operatively you don't get this. So in those cases, it becomes an indication for post-op RT. And the other, you asked about the post-op RT. I think you asked
The
about
target
target.
volume for.
Okay,
yes.
okay. So there are no guidelines which are recommending about how to treat these post-op cases. But definitely, if an APR has been done, so you have to, first of all, you have to treat the tumor bed. So you can take the help from your pre-op MRs. You have to treat the tumor bed. And if an APR has been done, so you have to treat the perineum also. So the volume comes down right till the perineum. And other than that, the lymph node regions are going to remain the same. The guidelines for the lymph node delineation is going to remain the same. So there are no well-defined guidelines which can recommend, but obviously you deal with your tumor bed, you give a margin of 2 to 3 centimeter, and then delineate the lymph node areas and treat the perineum. Go down because there is tumor seedling intraoperatively and they are the common sites of recurrence.
Yes, ma'am. Thank you, ma'am. Do we have to extend the CTV anteriorly 1 centimeter into the bladder, ma'am? Like in prostate.
See, if your post-op histopathology is not showing a T4 tumor, why do you need to extend it? Only if it is showing that there is some bladder infiltration. Or that means it is not a R0 resection.
Okay.
Then you have to.
Yes, ma'am. Thank you, ma'am. We have covered all the doubts.
Okay.
Over.
Okay. So I think I've shared my email. So if anybody has more doubts and you want to have some any further discussion, most welcome to mail me.
Yes.